Well, thank you. It's a real honor to speak at the Stomach Cancer Symposium. As a surgeon, I was just thinking so many times our interactions are in the hospital environment where we're trying to steal your modesty or stand over your bed, when I look at your wound. But, it's just such a luxury, really, to have some more time, and the patient panel was great. Really, that's a luxury that I don't often get during my workday. So thank you for that. Now, the talk I'm going to give is what I call my spiel. And so it's a spiel I give about 50 to 75 times a year. And it's for every patient that I see in a surgical consultation. So there is a disclosure there. It is, my opinion, but I'll try and keep it broad to be oriented to pretty much everyone. And there is an ask with it. So, if there is something that you feel that isn't on here that you thought would be helpful, I'd like to hear about it, because this is going to be a work in progress, and I plan on updating this frequently. So, just as a general outline, first I'm going to talk about general treatment approaches. I'll keep this broad, but just to cover how chemotherapy and radiation play into surgery, because that is very important. Then I'll talk about the risk-benefit to surgery. Then I'll touch on surgical technique and some of the anatomy, then the hospital course, the post-discharge course, and then just try and anticipate some questions. It's the common questions that I get in clinic, and try and answer those, and then touch on a few areas of controversy, and then some of the novel techniques we're trying one of our new clinical trials. So I usually start off by telling patients that chemotherapy and radiation is the icing on the cake. And of course, I'm a surgeon, so it makes sense that a surgeon would say that surgery is the most important part. But it does often offer the best chance for cure. But chemotherapy and radiation are very important, and just generally they can add 10% to your survival rate compared to surgery alone, and so that's a lot for gastric cancer. And so the options are a preoperative approach, meaning giving chemo or chemoradiation before surgery. That's neoadjuvant. Post-operative, also known as an adjuvant approach, or perioperative, also known as perioperative. But there's also some Asian and Eastern approaches. But I do want to highlight the difference between gastric cancer in Eastern versus Western population. And what I mean by East, just to define these, is Korea, Japan, Taiwan, China, versus the West, United States and UK. And what you'll notice, these are 3-year overall survival rates. So don't worry too much about the different studies and the words that, or the abbreviations that are listed there, but you can just see that survival is much better in Eastern populations than in Western populations. And so I get asked that a lot, why that is, and there are many reasons for differences. It's epidemiology, different risk factors, different eating patterns. There's some tumor biology that just may be different based on geography. Screening is much different in the two populations. There's a lot of early screening in the East. And then the extent of surgery may be important too. So at some of our surgical meetings, the Eastern surgeons will stand up and tell us they're much better than us, and they may be right because they do it a lot more often. I'll be talking about the post-operative approach, and I've used the Southwest Oncology Group picture here, the perioperative approach based on the MAGIC trial, which is why I have a picture of my favorite magician, David Copperfield there, and then the preoperative approach, which is primarily limited to something we do at Anderson, and then I won't talk about the Asian or Eastern approaches primarily. So, for the post-operative or adjuvant approach, this is based on the Intergroup 116 trial, or also known as the McDonald approach, which is surgery followed by chemoradiation. There's a 9% improvement compared to surgery alone, but it's important to note that 36% of the patients did not complete their post-operative chemoradiation. That can be primarily due to the effects of having undergone a major surgery, even sometimes a total gastrectomy, and they had pretty rigorous inclusion criteria where patients had to recover from the surgery, have all their tumor removed, recover, and have good nutritional status. But even then, 36% did not complete treatment. For the perioperative approach, that's primarily based on the MAGIC trial. And that's an approach of giving chemotherapy, then surgery, and then chemotherapy. Again, you see an improvement compared to surgery alone. In this study, it was 13%. But only 42% were able to complete all of the chemotherapy. Again, just highlighting some of the difficulties in giving chemotherapy surrounding the time of surgery. Next is a preoperative approach. Now, it's important to note there's no randomized clinical trials. The previous 2 studies were on high-quality randomized clinical trials. And all we have for this approach are some phase 2 trials, primarily instituted with Dr. Ajani at our institution. And that's giving induction chemotherapy, then chemoradiation, and then surgery. Now, really, there's an unknown improvement compared to surgery alone because we have not had those randomized controlled trials. I'll show you the survival data on the next slide. But it is a nice approach in the sense that 85 to 90% of our patients complete chemotherapy and chemoradiation. But it does require an extensive treatment plan. So first we start with a diagnostic laparoscopy. That's where we make small incisions in the abdomen, insufflate the abdomen with air, insert a camera, biopsy anything that looks abnormal. We'll often do washings, which is where we put a liter of normal saline into the abdomen, gently agitate it, take the saline out. If there's cancer cells in that aspirate, that makes the cancer stage 4. Also, sometimes we'll place a feeding tube during this, and that gets to be a real difficult risk-benefit discussion with my patients because, it is a foreign body that sticks outside of the abdomen. They have to flush it frequently. It can cause pain, discomfort. Certainly there's risks associated with bowel obstruction or infection. And then they often don't need it during the induction chemotherapy part, which lasts for 2 months, but about half of the patients will need it during the chemoradiation part that lasts for 5 weeks. So that means that half the patients have this feeding tube that they don't use. So I spend a lot of time discussing the risks and benefit of that. But you can see it's 2 months of chemotherapy, then 5 weeks of chemoradiation, then a 6 to 7 week break as the effects of radiation continue, followed by a surgery. However, with this approach, after the surgery, everything is done, and so our patients don't require any further treatment. This is our survival rate. I know the numbers are small here, so I'll just read them off for you. And these are looking at the 5-year survival rates, which is often where we draw the line at looking at our survival rates for patients that have stage 0 cancer, meaning they've had a complete pathologic response rate, which happens about 15 to 20% of the time with our approach. The 5-year survival rates are about 70%, stage 1, 63%, stage 2, 56%, and then stage 3 is 35%. But again, so there are no randomized clinical trials comparing the different approaches, but I do think it's important to note that chemo or chemoradiation is important to add to gastrectomy, so it is important to get that in. But really the approach depends on patient and physician preferences. There's not one right answer here. I think it just depends on the conversation you have with your treatment team and your surgeon on finding the right option. I do think, and I thought about this during the panel, that we do need more patient input on this and more patient-centered approaches in deciding what the right approach is because, especially with our approach, there are a lot of logistical issues. During the radiation, that's a daily treatment over 5 weeks where the patient has to stay locally to get that done. And you can just see there's a lot involved. So I think the logistics of which approach we choose can be very important. Okay, now next I usually talk with my patients about the risks and the benefits to surgery. Now the benefit, that usually is not a tough sell for surgery because it does improve survival. But I do spend a lot of time talking about the risks, and the risks are significant. So this is based on the American College of Surgeons quality improvement data. So this is population-based data from 2005 to 2010. And you see serious morbidity rates of 20% for partial gastrectomy and 29% for total gastrectomy. Mortality, and this is 30-day mortality, is 3 to 5%. Sepsis or severe infections occur in 6 to 9%. Having an organ space infection within the abdomen is 6 to 9%. Reoperation rate within 30 days is 6 to 10%. And then the length of stay is 12 to 13%. And it's interesting that gastrectomy is not included with a lot of the high-risk surgeries where they've done some volume outcome studies. So you may have heard of these more with pancreatectomy or esophagectomy or aortic aneurysm repair. It's like anything. The more you do, the better you are. Gastrectomy is often not included with that, but I think you could make an argument based on the risks shown here that it should be. And then I sound like a bit of a commercial, but then there's other risks associated, like heart attacks, strokes, pneumonias, blood clots, and a whole host of other things that can happen. There's the change in eating habits. We heard that quite a bit. And I tell patients it changes the way you eat, often for the rest of your life. Small, more frequent meals. Eating becomes a full-time job, especially with a total gastrectomy. With a total gastrectomy, there's a need for vitamin B12 supplementation. Now, there are no differences that we can tell in complication rates based on those different approaches I showed you, meaning you might think, well, is the complication rate higher getting chemotherapy or chemoradiation before surgery? As near as we can tell, that answer is no. And there are also long-term risks. Post-gastrectomy syndromes, again, we've heard about dumping syndrome, things called rheostasis syndrome. There can be bowel obstructions, hernias, even chronic pain. All of these things are important to note down the line. I was going to talk next about surgical technique, and often this starts with a diagnostic laparoscopy. The reason for that is it's nice to make a smaller incision, insert a camera, and look around before we convert to a full incision if that is the surgical approach. And then I'll talk about subtotal gastrectomy, total gastrectomy. I've drawn the line through proximal gastrectomy. You'll read about that sometimes. It's an area of active controversy due to concerns over disabling reflux and delayed gastric emptying, so I'm not going to talk about proximal gastrectomy today. A lot of my patients have come in and they've heard different things about surgery, and the reason for that could be if the tumor is located at the gastroesophageal junction. This is a junction between two cavities, so the thorax or the chest is up here, where the abdomen is here. And so they may have been told, well, you need an esophagectomy or you need a total gastrectomy. I'll tell you, sometimes we don't even know until we get into surgery and we've cut the esophagus, checked the esophageal margin, and know whether we've removed all the cancer or not. So that can be, an area that's confusing. So I'll talk just a little bit about esophagectomy. That involves encircling the esophagus, as shown here, and freeing that. It's primarily for tumors a little bit higher up on the gastroesophageal junction. But you can see it involves removing this part of the stomach, a limited gastric resection, and then turning the stomach into a tube. So if the gastric cancer extends beyond this area or even close to the area, they can prohibit this surgical approach. Here's just another view of what our thoracic surgeons do, where they turn the stomach into a tube, and then they make an incision in the right chest and place the tube into the chest. This is one view of how you might proceed with a diagnostic laparoscopy with incisions here, here, or here, primarily put in the midline. So if we do need to convert to a midline incision, we go right through the same incisions. This is primarily the incision that's used for gastrectomy. It's a midline laparotomy if an open approach is used. This shows one of the initial steps in the operation. This is removing the greater omentum, this fatty apron of tissue here, from the transverse colon. This shows some anatomy here. This is entering the lesser sac, dissecting the greater omentum from the transverse mesocolon. You can see the pancreas here. This is some relevant blood supply to the stomach. Here's the celiac trunk, splenic artery coming out this way, hepatic artery giving off rise to the right gastroepiploic vessels. Here's the liver here being retracted, gallbladder, stomach. This is what's referred to as the gastrohepatic omentum, making an incision in the lesser omentum. This is approximately how much stomach is left for a subtotal gastrectomy. You can see the blood supply primarily comes off the vessels from the spleen and the splenic artery. These are some images of reconstruction after a subtotal gastrectomy. So just a couple different surgical approaches. This is a hand-sewn anastomosis between the stomach and the small bowel. And this is using a surgical stapler to connect the small bowel to the stomach. And you can already see how this might change, eating habits when you remove 2/3 to 3/4 of the stomach. This is a reconstruction images after a total gastrectomy. And again, now you can really get a sense for why it might change eating habits. Here's the esophagus plugged into the small bowel. So you're going from using the stomach as a reservoir to really just having a couple small tubes where food has to move through pretty quickly. And so this is what's called the roux limb. And then here's where this is connected to the roux limb. And so the pancreatic and biliary fluid flows down this and mixes with the food. Oftentimes a feeding tube is placed, although this is just one technique for how to place that. Now, another area of active controversy is how many lymph nodes to remove, known as a D1 versus a D2 lymphadenectomy. So a D1 lymphadenectomy is removing the perigastric lymph nodes, and that's shown by the blue lymph nodes here. And really, these lymph nodes have to come out when the stomach is removed. So it's pretty easy and pretty standard to do a D1 lymphadenectomy. Now, the real question begins to do whether a D2 lymphadenectomy or not, and that means removing lymph nodes around the anatomy I just showed you, the celiac trunk, the splenic artery, and the hepatic artery here. Now, this is just a quick summary of the studies, and again, this is going to end with a bit of a controversy, but first there was the Dutch group, and what they showed was there was increased mortality with doing D2 lymph node dissection, but that was primarily because they were removing the pancreas and the spleen to perform the lymph node dissection, and there was no difference in overall survival between the groups. Now, at long-term follow-up of this Dutch group, the D2 group had lower gastric cancer-related deaths, so you could hypothesized that if you could do this operation safely and eliminate the upfront risk of mortality with removing the pancreas and spleen, that it could benefit patients from a gastric cancer standpoint. So then we had the Italian gastric cancer study group, and they eliminated removing the pancreas and the spleen, and what they found was that there was no difference in mortality. So we thought we had our data that if this can be safe, and we know that it improves gastric cancer-related mortality, that it should be of benefit. And so just up until recently, I was saying that yes, a safer spleen-preserving D2 is the recommended approach. However, now we've just recently, in September of last year, had the Italian long-term follow-up from this study here that shows no difference in 5-year survival. So what's the answer? Well, I think you can say that there's no clear data that doing the extended lymph node dissection works. However, in that Italian group, they did subgroup analysis and found that in certain groups, it did help. What we've chosen to do is continue with an extra-regional lymph node dissection, we call a D1+, and that means removing the lymph nodes as outlined here around the celiac trunk, and the hepatic artery and the splenic artery, not getting too much into the splenic hilum if it's not needed, but that is where your risk of blood loss goes up and even the risk of needing to remove the spleen. But the way this plays out in the operation is that if I think it's the difference between a blood transfusion, if it causes increased oozing, if it's an older patient where I think the risks go up, then I eliminate it and don't put the patient at increased risk, because I think it is only going to be of benefit if we can do it safely where it doesn't provide increased risk to the patient. Okay, next I often talk with my patients about the hospital course. And I always sound like a broken record for my patients because I'm warning them about two things. One is I'm telling them the hospital bed is their worst enemy after surgery. And then I always try and get them to use this little torture device here, otherwise known as an incentive spirometer. So on day one, I have the patient get out of bed, ambulate, just to decrease the risk of blood clots, pneumonias, try and recover bowel function as quickly as possible. And to use this incentive spirometer, it hurts to breathe after having an abdominal operation. So the patients tend not to take a deep breath, predispose themselves, the lungs collapse, they predispose themselves to pneumonias, and pneumonias are a big deal after surgery. Then on day two, I'll usually start tube feeds. We routinely place a feeding tube, but that's not always needed. That's also something that varies among institutions. Remove the nasogastric tube around day 3, start the patient on clear liquids day 4, transition to oral or per tube pain medicines around day 6, hoping for a discharge home around day 7 to 10. If there's any of those complications or bumps in the road, that can increase the post-operative stay. Now, I do ask the patient to stay locally if they're from out of town for 1 to 2 weeks. I think this is important if there are any bumps in the road after the patient has left the hospital. It's nice to have them in the area, get them back quickly, and take care of the issues. Now, post-discharge, I have a couple pictures here of some nutritional supplements, and it's just I tell my patients even before surgery, it's so important if they can find one that they like. And I think our patient panel even spoke to this a little bit. I know they don't taste good. When I was on call during surgical residency, I would raid the nutritional storage areas to get some of these things when I didn't have time to eat, and so I did not like them either. But I tell them. It's a bit like medicine, and so if we can find one that works, it just really makes that post-operative course so much easier. It's a meal in a can. But post-discharge, it's important to flush the feeding tube 4 times a day. The feeding tube can be a lifeline, and so if we need to keep that open. Have the patient return to clinic in 1 week. And at that point, there's no real textbook in transitioning from tube feeds to an oral diet if a feeding tube was placed. It just depends on how the patient's body responds. I'll tell you my average for having the feeding tube is usually about 6 weeks. This shows one type of feeding tube we have here. The black box signifies how much comes out of the patient's abdomen. And you know, I'll tell you, just something that's going to be coming up recently is they don't have a universal adapter for the feeding tube pumps. Sometimes they vary in size, but they are trying to come up with a universal sized pump. And so what that means is, from a feeding tube standpoint, if we use these, we're going to have to come up with a universally sized feeding tube. And so look for that to be coming in some efforts over the next year or two. Okay, now I thought I'd just touch on a few frequent questions that I get asked before we go into the patient questions. And again, the patient panel we just had was so informative, you know, especially with the why me question. And a lot of my patients ask me, you know, what did I do to get this cancer? Well, you know, here's some of the recent estimates on the risk of gastric cancer. Will have about 25,000 diagnosed for 2015, and often does not make it into the top 10 cancers that are listed here. And if you look at the lifetime incidence risk of gastric cancer, it's approximately 1% for a male due to the protective effects of estrogen. Again, women have a lower risk. And a lot of the risk factors are not things you can change. Gender, age, ethnicity, geography, blood type, not very easy to change some of those. But risk factors you can change, you know, H. pylori infection, diet, smoking, possibly obesity plays a role here. But what I think it's important to note is that when looking at the risk factors, you know, the relative risks vary among some of the diets, the risks associated with the different diets. Now, H. pylori, if you've had that for 10 years, it has a 2.5 increased risk. So this is one of the more serious risk factors. But even looking at a male's risk of 1%, okay, so if it's 2.5 times that, that still does not mean that this is, you know, what's caused cancer, and the overall risks are really still very low. Same with tobacco use, one of our more potent carcinogens. It's a 1.9 times increased risk. Family history is important. Blood type A is a very low risk. The risks vary among atrophic gastritis, pernicious anemia, operations for peptic ulcer disease. I used to tell my patients, the majority of the time it's just bad luck, but I have to be careful with that now, because there was this was a publication that came out that got a lot of press, and what it said was that, yeah, the majority of the variation with cancer is bad luck. That is due to random mutations arising during DNA replication in normal non-cancerous stem cells. But then there's quite a bit of blogging about this, and it got a lot of bad press and very controversial. And so, you know, I hesitate to use the word bad luck now. I don't want to bring up this controversy. But, you know, I think the short answer that I tell most of my patients is that, you know, you really haven't done anything to cause this. And I hope that alleviates what seems to be some of the guilt when patients come in. Another question I often get is the robot better? Well, it's certainly safe if it's feasible in the right hands. I think that's been shown. You know, not a lot of proven oncologic benefit. It is more expensive. It's more commonly performed in Asia for early stage cancer. But I think the bottom line is just finding a surgeon you're comfortable with. And, you know, these tools probably aren't a replacement for surgeon volume, and really just having a good multidisciplinary approach. Now, what about HIPEC? Hyperthermic intraperitoneal perfusion with chemotherapy combined with cytoreduction. You'll see this referred to as a shake and bake sometimes on the web. Sometimes the cytoreduction is referred to as debulking. And what this means is it's an aggressive surgical technique of cutting out all of the cancer and then treating with heated intraperitoneal chemotherapy. Now, it is accepted for appendiceal mucinous tumors. The survival rates are much better than with other approaches. It's still an area of controversy for colorectal cancer, but I think it is really of unproven benefit for gastric cancer. Major complications in 50%. Mortality rate is at least 5%. Median survival is not great compared to other treatment options. Most of the studies show a median survival of approximately 10 months. And so I do think you have to be very careful in choosing this as an approach. One thing we've tried to do, and this is a phase 2 study that we've just instituted at Anderson, is a clinical trial of preoperative laparoscopic HIPEC for positive cytology or low-volume carcinomatosis. So a lot of the risks of that surgery are associated with combining the chemotherapy and then a huge aggressive debulking surgery. And so what we're trying to do is, okay, if the chemotherapy and the heated chemotherapy works, why not do that first? Then if you get a response to it, can eliminate the spread of the disease outside of the stomach, okay, then we're talking about putting you through what I've just shown is a major abdominal surgery, which is a gastrectomy. And I'll show you just a couple pictures. So this is, sorry, let me go back one. So this is a view from laparoscopy. So the abdomen is a potential space. We've put a cannula in, insufflated the abdomen with CO2, and then we can look around. And so this is the stomach, and this white area here is where the tumor has grown through the wall of the stomach, making it a T4A. And once it's grown through the wall of the stomach, then it has the potential to spread or jump off and to grow onto the abdominal lining of the abdomen, which is what's shown here. And I get asked this a lot, well, why doesn't the CAT scan or the PET scan pick this up? This is very thin. It is millimeters in size, and so it's often below the size of the cuts of the CAT scan that we get. But this does make it stage 4 disease. And again, these are some other views. You can see just how tiny these little nodules are when they grow from the stomach to the abdominal wall, and why our scans can't pick them up. But if an aggressive approach like heated chemotherapy is going to work, I don't think it's going to work on very large tumors. If it's going to work at all, it'll probably work on some smaller deposits or patients with just having positive cytology. And so this is what we've come up with. If we have a patient with positive cytology or peritoneal disease that is just found on laparoscopy, meaning it's low volume, it hasn't shown up on imaging yet, then we'll treat it with our standard approach. And the standard approach is systemic chemotherapy. But then we'll discuss with the patient a laparoscopic HIPEC. It involves 3 small incisions, perfusing with the chemotherapy for approximately an hour. And then if there's no metastases on imaging, meaning no spread of the disease that we can see on our CAT scan, we repeat the diagnostic laparoscopy, and then if it has worked and resolved that spread of disease or the cytology is negative, then have a risk-benefit discussion about whether a gastrectomy would help. This is an intraoperative view of what that technique looks like. Here's the incision that's been closed for the camera, for the laparoscopic camera. Here's an inflow cannula. Here's an outflow cannula. And that's how we perfuse with the heated chemotherapy. This is our perfusionist. I made fun of him. He looks a little too goofy in this. He's usually much more serious. But this is the perfusion machine that we use here, and it just puts the heated chemotherapy in, and out it comes, and we circulate it using this perfusion pump. During this time, the abdomen is agitated to wash the chemotherapy around. So just some early results. It's really too early to say whether there's any benefit to this. We just don't know. So I want to be very frank about that. We've enrolled 9 patients over less than a year. Now we have had 3 patients go on to resection, but again, being very transparent, so far it's only been patients that have had positive cytology. We have not been able to make many inroads in the patients with carcinomatosis, and we may need to revise this study based on those results. But what has been good is we haven't hurt anybody in the sense of having even minor or major morbidity. The average hospital stay has been 3 to 4 days. We're very cognizant of the fact that we can cause renal injury with some of the kidney injury with some of the agents we use, so we're being very careful with this approach. But thankfully, we have not had any complications. And again, survival, really any benefit to survival, I just cannot state that yet. It's too early in follow-up, but we are being aggressive about looking at some of these new techniques. Okay, so that's all I have, and I'd be glad to answer any questions.
Thank you very much. We're going to thank you. We're going to open it up to questions. We have a lot of questions. We have one here in the front, please.
Dr. Badgwell, it is an honor to meet you. I am a 13-year stomach cancer survivor from British Columbia, Canada. They did the total gastrectomy on me, but what they've done different with me is they created a pouch. I mentor a lot of people all over the world, especially through Debbie's Dream Prep, and that's the big question I'm getting. Why did they give you a pouch and I didn't get one, and you're a 13, almost 14-year survivor? So I always tell people, please go back to your surgeon and talk to them about this. This was amazing. You answered a lot of questions, and I would like to talk to you after this. We don't have the time today, but right now. But I wanted to say, why am I extremely rare with this pouch? And look at me. And I eat pretty well everything.
Yeah.
You wouldn't even know I'd had a total gastrectomy.
Right, that's a great question. I should have included that as one of my common questions, because I get asked about the pouch a lot. I get asked about, I don't know who's written about putting pig stomachs in people to replace the stomach, but that's not accepted. but you can live without a stomach. But you're right. And so to answer that question, what we really need is a study where we've compared patients with a pouch versus no pouch. And we just don't have good data that improves long-term quality of life. And so I'd say that is an area, again, of controversy. We just don't have enough studies to suggest whether we should be doing these techniques with a pouch. I think a lot of the benefit is relatively short-term. Of course, that's just my opinion. And I think long-term, I can probably get somebody without a pouch to the same level of quality of life, but an area that does need to be studied more, for sure.
Doctor, I have a question as to chemo, radiation first, then surgery, or surgery, then chemo, radiation. There was approximately 3 months of time that goes by when you're doing the chemo, radiation, and then surgery. But is there any measurement of what risks you're running of the cancer spreading while you're doing this pre-operative process? And the debate before or after now, as far as surgery, leaves a lot of question.
Exactly. No, I think you've just asked, the fundamental question among those various approaches, and I think we need to have better studies comparing that. We run about a 15% risk with this preoperative approach of the cancer progressing are getting to the point where we can't do surgery. We think that those patients would not have been helped with surgery because they're not showing a response to the chemotherapy or chemoradiation, but we don't have good data to suggest one approach is better than the other. And so I do have to be, it's a preference, and I think we need more studies about what is the optimal approach. I will say ours is a selective approach, meaning that we feel that if we get to surgery, that those are the patients that are going to be benefited most from surgery. But yeah, that's a great question that needs to be answered. Yeah.
Great, we have quite a few questions. We have one online, asks, what are the surgical possibilities for stage 4 patient if his main tumor mets have shrinked or disappeared? Specifically, in our case, the tumor is in GE junction and 3 spots were initially found in the liver.
Right. So this is a question we're getting more and more in our multidisciplinary board. The standard of care is systemic therapy for that. Now, I'll tell you, and we just recently published this month in the Journal of Surgical Oncology about this is an uncommon clinical scenario, but about in 1% of our patients, the metastatic disease will disappear, and then we're left with this very difficult situation of what to do. Now, for the gastroesophageal junction tumors, it's relatively, it's easier for us to decide because we can treat with chemo and radiation and good primary control, sometimes even complete control. And then, of course, we wouldn't put the patient through a surgery unless that tumor came back, or certainly if there were any symptoms. But I will say occasionally we get into situations where if all the tumor has disappeared and the patient has had a long disease-free interval, often on the order of a year or more, that we will proceed with surgery. But we do not know if surgery helps that patient or if we're just selecting out the patients that have favorable biology and they would have lived that long anyway. Again, such a rare situation, we don't have good comparison studies.
Okay, thank you. Hopefully online you heard that question. I have another question here. It's a little long, so I'll read it. It says, at stage 4, many patients search for that one surgeon who will perform surgery. So for those who have found a surgeon willing to perform that surgery despite distant metastases, the question is, what are current survival statistics, number 1, and number 2, what are the additional risks these patients face?
Right. So some of that I can touch on. I think when most patients are having surgery in the setting of stage 4 disease, it's usually somebody talking about the HIPEC and debulking. And again, I just think the risks are significant and the benefit is largely unknown. So that's not something we do as part of our standard of care. And in the I think the risks do go up, in surgery for stage 4 disease. So I think you have to be selective and just have a clear understanding of the risks and benefits. But occasionally, we will do it in the right situation if there has been a long disease-free interval. But it's a very, those are the toughest clinical decisions we have to make. So I don't have a real clear answer for you.
Thank you. Another question is, what is the incidence of stricture post-op? And what are the causes of stricture in anastomosis?
Right. So it depends on the surgical technique. So with a stapled anastomosis, and what they're usually using is they size these things differently. If you use a size 25, which is one size that the stapler comes in, the risk of a stricture is significant. If you go higher than that, you can decrease the risk of stricture. A lot of it's surgeon preference. I'm pretty conservative as a surgeon. If surgery was politics, Fox News would probably be too liberal. So I hand sew all of my anastomoses, and so have a very low stricture rate just because I don't use the stapler technique on the esophagojejunostomy. But it's probably, looking at stapled techniques, probably on the order of 5%.
Okay, thank you. We have a question in the back of the room.
Dr. Badgwell, what is the temperature of the chemo that you're putting into the stomach?
Right. We have to keep it less than 42 degrees Celsius. If it gets higher than that, then we run the risk of burns. You can get pancreatitis. So that has to be very closely monitored by our perfusionist during the case.
And what is the rationale for using it heated?
Heated, yeah, that's a good question. We don't know. It was one of those things where people have started using heated chemotherapy, and we don't really know how much the heat works, but the heat improves the penetration of the chemotherapeutic agent. And in addition, heat may have a direct effect on the tumor cells.
We have a question in the back.
Yeah, question. Feeding tubes, I was interested. You had I'll call it the infamous red one, but there's also ones with air balloons and stuff. Which do you prefer? Because I had situations where red tube came out. The second, third, fourth one were the air tubes, and it was always at inconvenient times on holidays or middle of the night. But which one do you recommend? Because just so you had just the red one with no securing to not come out of the stomach.
Right. And so, and I get into that situation as well, where if my feeding tube comes out, I'll ask one of my interventional radiology colleagues to place it back in. They typically use a feeding tube with a balloon on the end. I just have to be very careful about using a feeding tube with a balloon on the end initially, because that balloon could cause an obstruction in the bowel. And if things obstruct, all of my hard work upstream could be at risk from increased pressure. But for whatever reason, when my IR colleagues place the feeding tubes with the balloons on it, they don't seem to get in as much trouble. And you're right, it does have the added benefit that it's less risk of coming out. So.
Okay, great. I have one last question. What if a severe reaction to chemotherapy, specifically Xeloda, which is a 5-FU, in pill form, leads directly to surgery and chemo cannot be done after?
Right. And that happens. And it's okay to switch approaches. Again, as a surgeon, surgery is the most important part. So if that's gotten taken care of, and the benefit to that is then you'll have the post-operative pathology to help you guide your treatment decisions. And then you could look at maybe switching to a chemoradiation approach, or perhaps finding a different chemotherapeutic agent, or maybe the pathology, wouldn't require the chemotherapy anyway.